afternoon, we continue to talk about the intraoperative management of anesthesia. Now we talk about regional anesthesia, including spinal and epidural anesthesia. Local anesthetics. The first one is local anesthetics. Most commonly, most clinically, local anesthetics contains a lipid soluble benzoylene connected to an amide group and categorized as either two types of local anesthetics, right? And this is the structures of local anesthetics. The mechanism of action of local anesthetics is block passage of sodium and through membrane with the sodium channel, and the local anesthetics can also block the nerve fibers transmission, right? The signal transmission. And this chart is about nerve fibers and their sensitivity to local anesthetics. We can see the different types of fibers of nerves. And some is myelinated and some unmyelinated. And they have different diameters, right? And also their conduction velocities is different. And the sensitivity to local anesthetics is also different, right? And the function is different. Usually the myelinated is local section and usually large motor, and also this one is sometimes transfer the signal of temperature or touch signal or dull pain, something like that. And this chart shows common local anesthetics, and this is classification of the esters, lidocaine, tetracaine, and amidase. The most used one is lidocaine, right? And their potency and the onset time, duration of the action is also different. And also the maximum signal doses is also different. We can see the lidocaine, the most common used lidocaine, and the dose is, I think, 300. And local anesthetics can cause side effects. One is systemic toxicity. But if the plastic concentration of local anesthetics is high, it can cause the systemic toxicities, and they usually result from absorption of local anesthetics from the tussle inject sites to the circulation, and the amount of the local anesthetics into the vessel blood and into the circulation depends on the doses of anesthetics injected and the vascularities of the injection site, and also inclusion of vasoconstrictors. The manifestation of systemic toxicity is central nervous system. Sometimes we can see the patient has some kind of symptoms. For example, restlessness and vertigo, sometimes tinnitus and slurred speech or tonic seizures. And if patients suffer from tonic seizures, we can give a treatment to stop it. For example, diazepines, Cypental, or muscle relaxants, according to the seriousity of the seizures. And sometimes maybe need supportive ventilation, or need to give oxygen, for some special patients. If the seizures is very severe, we should give the intubation to a patient to maintain the ventilation. And also the local anesthetic can also cause some cardiovascular system, because the toxicity can influence the cardiovascular symptoms, especially the high dose in the circulation. For example, hypertension or myocardial depression, and sometimes can cause cardiac arrhythmias, and also especially higher lipid soluble and fast sometimes can cause methylbulimia. We should get this one right. And some patients suffer from neurotoxicity. So if patients have some neurotoxicity, we should give some treatment also. And some patients can suffer from allergic reactions from local anesthetics. And if patients suffer from systemic or local or systemic toxicities, we should give a treatment immediately. And usually, the common treatment is first we should maintain the hemodynamic stable, the proper ventilation, and then we can give some medication. Right? And second one is the anatomy. And we can see this is the spinal column, right? Spinal column. This is lateral side, and this is posterior back spinal column. And cervical is 7, and thoracic is 12, and lung 5, and sacrum 5, right? We should be familiar with this one. And the spinal cord fills, right, spinal column in maybe less than 1 year old, and ends at number 2 to number 4 in children. This shows dermatums, the dermatums of the spinal nerve. Cervical spinal nerve, the dermatal terms, and we should usually we should say in the thorax scan, and then this is thorax 10 usually, and the nipple is thorax 4, right? And as an anesthesiologist, before we start the anesthesia, we should give a good preposition. And one is preoperative preposition for renal anesthesia should be the same as for the general anesthesia, for monitoring and the evaluation, preoperative evaluation of the patients. Second is don't encourage patients against their wishes to accept regional anesthesia. That means if patient unwilling to accept regional anesthesia, we cannot push him or her to select it. Especially when we do the preoperative evaluation of the patient, the specific problems we should pay attention to. One is examine the back, right? If the puncture site have any infectious or if have any infectious, we cannot give the epidural or spinal anesthesia, and also the deformities. If the patient have some deformities in the back, on the back, and another one is coagulation status. It's very important. If the patient have the coagulation status is not normal, we cannot give the puncture, right? We should delay the procedure if the patient is on heparin, or we should give a proper evaluation of the coagulation status, and then we make a decision if we can give the epidural anesthesia or not. And also, this original anesthesia is contraindicated in sepsis and not considered in patients with who is hypovolemic, for example, bleeding, very severe bleeding, or very severe dehydration patients. And we should give proper medications, make the patients under sedation, and some and also need monitoring, for example, SpO2, heart rate, or blood pressure. And we should make the proposition for the emergent equipment and the drugs which are available. And spinal anesthesia. Spinal anesthesia follow different surgical procedures. We can see we give the different level of which the the different level of the spinal nerves. That means we should block the different places of the body, right? For example, this is a type of the surgery. Rectal surgery is usually sacrum 2 to 5, right? And foot surgery usually lumbar 2 to 3, or knee sometimes. Lower extremities usually give lumbar 1, for example. We should, according to a different surgery, to block the different places of our body. And the levels and durations of the spinal anesthesia is different. We can according to the different situation, we can give different level of spinal anesthesia, and the distribution of the local anesthetic solution in cerebrospinal fluid. Yeah, cerebrospinal fluid, right? Depends on the velocity to the solution and the contour of the spinal channel. And the third is the position of the patient during and in the first few minutes after placement of the drug. And also different from the types of local effects, and the different from the presence and the absence of vasoconstrictors. And also the duration of spinal anesthesia depends on the drug selected and the presence and absence of vasoconstrictor. The duration of spinal anesthesia depends on the drug selected and the presence of or absence of vasoconstrictor. This is concentration, the lidocaine, tetracaine, bupivacaine. Those volume and onset and duration, and the different anesthetics, right? Local anesthetics is different, right? We just say lidocaine, the concentration. If we give 5%, and this is dose, different volume, and the duration is different, right? And the velocity and the position is also influence the level and duration of spinal anesthesia. For example, hyperbaric, adding glucose to local anesthetic solution and heavier than cerebrospinal fluid. And the most dependent aspect of spinal space, mostly commonly used, we most commonly use the hyperbaric, right? And hyperbaric, we usually adding 6 to 8 milliliter sterile water, and the solution floats in spinal space. This kind of spinal anesthesia best for surgeries in jackknife or lateral position. And the last one is isobaric, diluting solution with cerebrospinal fluid. And the commercially available solutions are isobaric, and often used in hip surgery. Usually number 1 or below number 1. And, physiology of spinal blockade is for the unmyelinated small diameter nerves are close to surface of spinal cord, and therefore are blocked first. And the sympathetic, usually this kind of sympathetics. If the sympathetic nerves blocked, patient may be exit hypertension if we haven't paid attention to maintain the hemodynamic stable, and the block exceed sensory dermaton, right? Sensory dermaton. It means block usually exceeds sensory derma. Yeah, it means sympathetic nerves block usually exceeded the sensory dermatons. And the myelinated large nerves, usually sensory and the motor nerves, are blocked following sympathetic block. Means first sympathetic block, and then is sensory and the motor blocks. We can use alcohol sponge procedures to warm and neutral the surface in blocked areas to see that if the block happened. And the loss of, we can see the patient loss of motor movements in blocked areas, and up to 2 dermans lower than sympathetic block. Usually little effect on ventilation, right? But high levels, if the block level is very high, also can decrease cough or cause dyspnea, and it can increase the blood flow in the lower extremities, reduces the incidence of deep vein thrombosis, and we should prevent bleeding, right? Spinal anesthesia also has some kind of complications. One is hypotension. Very often happened. And hypotension usually result from sympathetic block. And when the spinal anesthesia blocked sympathetic nerves, the blood returned to the heart decreased, the cardiac output decreased, and peripheral vascular resistance also decreased. and sometimes heart rate decrease. So these all the reaction of the cardiovascular system can cause hypertension, right? So at this time, if the patient exists hypertension, we can use volume, give some volume fluid to treatment, and also we can give some constrictors to raise the blood pressure of the patient, and also we can give a head down sometimes, right? We can try head down to increase the blood return to heart. And except hypotension, another one is post-spinal headaches. The headache may be located in frontal or occipital place, right, of the head, occipital of the head, and worsen by sitting or by a walk, improve by supine positions, and usually caused by cerebral spinal fluid leak. We can give some patients prescription to treatment post-spinal headaches. For example, we should make patient rest on the bed, and we can give some fluid, right? And for the severe patients, we can give blood patch at abdominal. And another one is higher spinal blockage. Usually because of undesired excessive level of sensory and motor blocked, and the patient is difficult breathing and may sometimes suffer from hypoxemia and hypocarbia, and sometimes from apnea. Usually have some accompanying symptoms. For example, blood pressure is low, and sometimes patient nausea, and patient sometimes suffer from agitation. And we can use for this patient, we should give some support for breathing and circulation. For example, gives oxygen. If needed, we can intubate the patient, and to maintain the ventilation of the patient. And also we can give head down, or give some blood, or give some fluid to maintain the stable hemodynamics. Hemodynamics. And the patient could not have acts. And another one is nausea. Nausea usually because to hypertension, brain ischemia, and may also be due to relative strong parasympathetic activity in gastrointestinal tract. And we can give volume fluid. We can give vasoconstrictors. Sometimes we can give atropine or some drugs to stop the nausea. And another one is urinary retention, and usually because of the blood retention, and sometimes may require catheter drainage. And also patient can suffer from backache and neurologic sequelae. It is rare. Another one is epidural anesthesia. For different surgical procedures, we also should give different spaces to block, right? For example, here, this type of surgery, rectal, foot, right? We should give different the range of the block. And this is epidural space, right? if we do the epidural puncture, usually we should let me see. Yeah. To get into the epidural space, first of skin, from skin to subcutaneous tissue, right? And then to subspinous ligament, and to intraspinous ligament, and then to the ligament labium, and into the epidural spaces. This is the epidural spaces. This is the middle, right? And the level of and the duration of epidural anesthesia is also different. Depends on the volume and the concentration of local anesthetics. Usually needs 15 to 25 milliliter to achieve sensory levels for surgery. And also depends on presence and absence of epinephrine, right? But we should pay attention. Some places, the surgery of some places